this is a program that everyone in the past years has really liked, the review of literature. So these two nice people that volunteered to do it is, in case you missed it this morning, this is Andy Phillips. He's an assistant professor at the MGH Institute of Health Professions, School of Nursing, teaching nursing informatics and research methods. He also holds an adjunct appointment as assistant professor of clinical nursing at Columbia University School of Nursing, teaching health policy, AKA friend number one. And Kathleen Keough holds a PhD in nursing and health policy from the University of Massachusetts, Boston. Her research and applied policy practice is focused on leadership as an aspect of nursing practice. Since Chapter 305, a health reform in the Commonwealth, she has served the HIT Council on Workforce Development and Consumer Engagement. She teaches evidence-based practice in health informatics at Simmons College. Thank you for agreeing to do this program again.
And I am soul sister to friend what, two? Thank you.
All right, having listened to my introduction twice, I just want to make it clear I do have research interests, because I don't think they were on there, but I didn't put any. But I do actually have research interests, and I do some research. But anyway, a couple important things I just wanted to lead off with. One, it's important to show up to these meetings. I was not here last year, and I am now standing here. And when Mary's phone rings, you pick up and you say hello, and she says you're doing this, and that's how it happens. So it was a pleasure meeting you, Mary, beginning last year, and glad to be here. So up to two now, right? A lot of information. Wow. What a lot of work that Sarah and Patty did, and they should be applauded for that work, because I have a new pair of glasses now, all sorts of stuff like that. So I just want to do a round of applause for them. It was actually a lot of fun to read all of this literature. I learned a lot about what's going on. I learned things that I didn't know before. I have stacks of paper in my office at home. My wife thinks I'm absolutely nuts for enjoying reading all this stuff, but what a large amount of information to read and learn. So it was a great experience to go through, and I hope I can do this again, because I really think it was a lot of fun. We found that the trends make sense, which was kind of interesting, right? So what we know about nursing informatics, the trends that we're about to go over actually do make sense. But sometimes they're not what we want or don't expect necessarily. We bring, I'm going to say it right up front, we bring our biases somewhat to this process. I don't know how to undo that. I think we can try as hard as we can, but you'll see that there's probably some biases there in what we present. We miss a lot by starting from scratch here. Patty and Sarah have been doing this I think Patty started this in 2012, and then some combination of Patty and you have been doing it ever since. It might have been earlier, but I look back, I think that was the first one I found, and Patty did it. Patty's name was on it. So one of the things I think that we miss is, having done it for 5 years, we miss some of that trend. So keep in mind that we're starting from scratch. We can go back and look at some of those prior presentations, but we didn't read all of those articles from before. So there's some sense of us starting from new. It's impossible to pick articles. I could be up here for 2 hours talking about articles that were of interest, and it was a difficult process to do, and I think that's where some of the bias comes in. We picked the ones that stuck out to us because they were interesting, reflected some of the trends that were out there. And I think that's it. So I think we are ready to begin. Button, please. So I think this was said at the beginning, but it was in the prior slides. No conflict of interest. I have no financial interest in doing this particular project. Just want to let you know. Our learning objectives were to evaluate themes that impact nursing informatics. identify gaps in nursing informatics research, and generate logical next steps in advancing nursing informatics research. So hopefully in what we talk about and conversations that ensue in the halls and afterwards that we identify these things. We have discussions about these things. Methods, I think Mary introduced me at one point as the methods guy. So not only am I friend number one, but I'm the methods guy. So in that spirit, I have a citation and a method. So we are doing a scoping study, which has a bunch of steps, which you see there, and we're going to follow those steps in our review of the literature and looking at the trends in nursing informatics. So step one is the research question. So what trends and themes emerge from a survey, and how do we make meaning of the current and past themes in some kind of a historical context? And again, some of that history is hard to pull in because we haven't been doing this every year, but we're trying. Step two, identifying the relevant studies. So we use databases PubMed and CINAHL. We use the following search term: nurse or nursing and informatics, or nursing informatics. And that got us a sizable number of articles, so we left it at that. And we looked at the dates from March 1 to February 28th, 2017. So one of the new issues, and I don't know if it's new or not, but depending on how you searched or which database, a lot of publications are done online and then republished in paper and then somewhere else. And so you have publications that appear 3 different times to 3 different dates. And so there's probably some articles here that might have a date after or before some of these dates, and we just took the one that popped up first, I guess. But we do have this, I don't know if it's new, but it certainly was apparent as we were doing these searches that you have these kind of roaming publication dates now. It was published first electronically, and then it was published in another format later. Step 3, inclusion and exclusion criteria. So we've tried to keep these as consistent as possible, but I have one note that I want to add, which is, so the inclusion criteria was that to be research, contributes to nursing informatics, prototype development and testing, clinical care delivery focus, and informatics. Exclusions were articles that focused on informatics education programs, nursing education, nursing students, competencies, and simulation. So these were the same exclusion and inclusion criteria as have been used in past years. Simulation, I want to just make an argument that we might want to start including, because I don't think it means the same thing as it did 5-6 years ago. It also happens to be the area of research I'm interested in, so it'd be really nice to get that out of there. The argument is that simulation can be more than just simulation labs, which I think is where it started with the education piece. And simulation now can also talk about looking at population health trends, modeling populations, looking at progressions of disease states, things like that. So I think there's more to simulation now. And in future years, I think we will try to include some of that. But kind of, again, trying to separate the education piece from some of the other pieces, because I think simulation is becoming, and some of the power and big data, all those things around big data and genomics, a lot of that is kind of simulation, right? You're using a lot of statistics to predict things. You're using a lot of other kinds of tools and computing power to accomplish different kinds of tasks, which could fall within that topic of simulation. So I'm making an argument to include that, and if I am asked to return, which not sure yet, but if I am, I will probably start including some of that kind of research. Or we, sorry, I didn't mean to say I, Kathleen. All right.
Soul sister, maybe.
Yeah, well, that's right, you don't get to speak anymore now. All right. So as I said, we found a lot of publications. We started off with that search. If I add those up, that's 599 publications that we came up with. That's a big number. But that's typical of a scoping study. So a scoping study, you're supposed to get this big net, go out there, find what's out there, and then try to narrow it down, but not too much, because you don't want to lose kind of the themes and what's going on out there. So we started off with 599 publications from those 2 databases. 36 were duplicates, leaving us 563. We looked at 563 abstracts. Wow.
It was fun. It was fun.
I have a box in the car, just in case anyone wants to look at any of those articles that I missed. But we looked at them and got rid of, thankfully, 426 of them. I guess we could have done a title search in retrospect, but but when you print it out in RefWorks or something,
Yeah.
the title and the abstract are there, and your kind of eyes kind of go down anyway. So it's an abstract review. We then, of those remaining 137, we did a full text review of those 137. 8 of them we couldn't find or weren't in English, and so we actually looked at and evaluated 129 articles. So, a much, thank you. So, big number, little number. My mom always said that she was really bad at math. So if I had to talk to her about budgets or how much things are going to cost, I just had to tell her what was a big number or a small number. I need a new car, big number, and she would understand it. So we, and she said no, by the way. But as you can see, there is a lot of there's a lot of published work out there in informatics. It is definitely growing. We are definitely getting more recognized. It is being published in higher and higher profile journals. And I mean, so this is good. The fact that it's up there, it doesn't help us up here, but this is good for nursing informatics in general. All right? So, big number. So, either my fault or someone else's fault, but we don't have the list of the publications from people in this group. So can anyone who published something
Yeah.
this year raise their hands?
Who did we miss?
You got to be kidding me. Who published something in the last year? We did.
Yeah.
I did.
Well,
Friend number 1. Thanks to
else.
Sarah, published something. There we go. All right.
no, there's someone, Andy, right?
Oh, good.
It was in population health though, so not quite nursing.
Population, see, simulation, population health, looking at these large populations, looking at data differently. See, we are going to include this
We need to
moving
get
forward.
that. We need to get that.
All right. Okay. So, these are similar slides to what we've seen before, and I've done one additional thing, again, because I don't have the experience of the past. So I tried to put some of the past in here. So research settings are in this pie chart. Ambulatory is the largest, followed by, if I do my colors right, long-term care, followed by health professional expert panels, et cetera. So it's starting to change. And so I tried to put up here kind of what these things look like. See if I have this right. So we have this growing breadth of settings. So if you look at some of these things like hospital, all 5 years we have some numbers out there. But some of these other ones, and again, these are arbitrary because we're just sitting here trying to allocate an article to a specific setting. But the breadth of things that we end up writing on a piece of paper or on a big whiteboard is growing. And some of these, rightly or wrongly, should be there, but we're seeing this growth in the kinds of settings that we're seeing articles in. Categories are becoming harder to distinguish, right? So we look at ambulatory, community public health, continuum of care. A lot of these things start to feel the same when you read these articles, right? So if we're talking about ambulatory or community care, is that part of the continuum of care? Because you're going from here, you're going to discharge, you're going to somewhere else. So how do you identify or put in a hole or a slot these kinds of categories? So it's becoming harder. It's hard for us to kind of distinguish at times where these articles fell. So that's another area that we'll need to focus on as we move forward. We also saw trends toward non-high-tech settings. So we've had this period of high-tech and implementing, and we see the number of articles about hospitalization that we categorized as trending down, but we also see long-term care, places where there hasn't been the meaningful use money starting to trend up. So that's one of those areas where, gee, we kind of expect that, right? We have all these hospitals that everyone has been spending all this money putting stuff in, and we now have to start dealing with all those places that didn't have technology. How do we start dealing with discharges, transfers, that continuum of care piece? So that's a trend that we noticed. And then systems have become settings, right? So it's no longer a specific place. You have a system that's a setting that includes a bunch of other kinds of things. So that's just some of the stuff as far as settings. By country, this has been the same. This has not really changed much. It's the US. The method here has been the first author. So the country of the first author is what creates this chart. And I will say that having read 129 articles, the second author sometimes is more important, because if you look at the country of setting and you look at where the research actually took place, it took place where the second author was from. So if you did this chart again differently, I did not go back and reread 129 articles to redo the chart, just letting you know that right off the bat.
There's a way to do this.
But just in a very qualitative way, I think this would look much different if we looked at where the research took place and who were some of those second authors, because we see a lot of the same first authors, a lot of the same organizations doing the studies or managing the studies or funding the studies, but where they're taking place is much broader than what I think this picture depicts. So a lot of research was actually done in Iran and China and Korea, but that doesn't show up as necessarily in this chart. But when you read it all, you go, wow, look at all these different places where nursing informatics is now playing a role that wasn't playing a role before. And again, it doesn't appear in these pictures or numbers, but from a qualitative perspective, when we take a step back and look at it, we're seeing informatics spread a lot more than this chart might say. Topics. This has been a slide, again, that's been around for, again, I went back to 2012. And these topics, again, change. So how do you fit things into holes or columns? And these were the topics that we came up with. The biggest topic was telehealth mobile. I think that's been relatively consistent over the years. I have my next chart. Go back one. But yeah, the health mobile. But things like patient empowerment, what's the other one? Workflow. Those kinds of things are becoming more and more prevalent in the literature we're looking at. Our first speaker, Jane, she's still here. I counted the number of times she said process and workflow from actually all of our speakers. And that comes up a lot, whether it's disasters or whether it's how do we reorganize our organization, how do we implement things. Process and workflow are appearing over and over and over again. And again, that doesn't show, again, I think, the number of times that you see that concept in these papers. It's a much bigger number than that. But again, if we're trying to put it in a single place, for example, telehealth mobile, you need a process to go around how to make that work. So it may be a telehealth mobile article, but it talks a lot about the process. How do we make it work? How did we implement it? How was it received? How was it accepted by patients? Those kinds of things. So some of these pictures are becoming hard to interpret. And I think one of the things that we'll do as we go forward is try to think of other ways to try to present some of this data, because pigeonholing it is becoming murky based on kind of the advances and the speed of change that's taking place. I don't remember why I circled these. But it's really important.
It's a little redundant.
All right.
Yeah,
Yeah, I think I circled technology acceptance, implementation workflow, telemedicine, big data. Yeah, I really don't remember why I did that. But anyway, these are all the topics from the last 5 years put on one chart with some kind of trends. Transitions apparently was really big in the 2014-15 year, so, but otherwise we kind of see some ups and downs going through there. Yeah, okay. All right. So, step 5, again, following our methodology, which is we read all this stuff. Kath and I sit and talk about it a lot. She tries to convince me to play golf every time I go visit her. Even though it's raining, she says it's okay to play in the rain, and it doesn't matter if I didn't bring a coat and I'm going to get all wet, but that's all right. We can still play 9 holes or 6 holes or whatever. I'm sorry to pick on you, but I just, we did sit together a lot and go over these and talk about them and try to identify themes that we saw coming from these articles. So these are the themes we identified. So again, a little different than last year. This is a little bit of qualitative pieces going into this, into the presentation. So the themes really centered a lot. I've highlighted the word patient a lot because a lot of the themes, we couldn't write the theme down without putting the word patient in there. So that's a good thing. It's a good thing to see that word a lot more as we go around. They ultimately are the consumer. So direct consumer involvement, patient engagement, those words were said a lot. Process, workflow, outcomes, quality improvement, all of those kinds of things were said a lot. Public health, right? We have a public health publication here, public health reporting, the concept of the learning health system. There was I can't remember, I was going to say it, one of the slides up here is an exact picture of the learning health system with the zigzag and the 9 blocks. I forget what presentation that was, but that's a learning health system. You get data, you go through it, you learn from it, and you go back and get more data and try to continue to improve the process. So again, more workflow, that kind of stuff. Transitions of care, big data, data mining, public population health, precision nursing, cost effectiveness, identification of value. So how do we start valuing what we're doing? So it's not good enough now to just do it. We need to provide value as to why we just spent $1 billion on a new piece of software. Culture. Culture was a big thing that came up. So we need to be more culturally sensitive with this. Who would have thought informatics had, well, a lot of people thought because we had it as a topic. But I think it's important. You know, culture, setting, where we are is a huge piece now of patient care, and it's coming out in the informatics literature, which was nice to see. Technology acceptance, we've thrown all this technology at people. Are people using it? How do we start looking at technology acceptance? Care coordination, huge piece of meaningful use, that whole transitions of care, care coordination, all that. And we're starting to see that as well, and again, including that patient in the process. Movements to new cares of setting, again, kind of the same, that transitions of care thing. And then the reevaluation of IT. We've had IT around for a long time, right? It's not new that all of a sudden we're spending all this money. We've been using IT in both nursing and other places for a long time. So we saw a number of articles that started talking about how do we reevaluate some of the technology that we already have out there. Is it still helpful? Is it still usable? We just heard a presentation about a disaster. Some of that old technology might be the technology that you end up using more in those kinds of environments. But there was a number of articles that started talking about how do we deal with the old technology? How do we talk about it? Is it still useful to us? Or should we just scrap it and move on to whatever the next thing is? So those are some of the themes that we came up with on our big whiteboard at the golf course. So we're going to take turns now going over some of the articles. And again, remember caveat number 1, we're not perfect, we make mistakes, and there's absolutely no way we could have gotten all the articles included in here in 45 minutes, of which I just used 25 of them. So anyway, Kath, it's all you.
All right, well done. This has been fun. Andy is just terrific to work with, and this is so much fun to do this work. And there was more than the golf course. There was you could shoot baskets. I just wanted him to get away from the computer for a period of time, walk around, and shoot a few baskets, and then we'd get back into the conversation, honestly. Let's see if I have you went through these, correct? Themes?
No, you're going now.
Wrong
You're
way?
going backwards. So
Sarah did this one year.
you go, there we go.
Bingo! Right direction. So some of the themes, as we discussed, sort of coalesced into this notion that there exists this potential for deep structural change in our healthcare delivery system as we begin to better capture the person's story. And Mark Shagru has a great slide, pie chart. We're only patients like this slice of the pie. So I want us to lose that patient. It's really the person's story. Being a patient is part of it. And it's very multidimensional. The person's story is very multidimensional. So we're trying to support engagement and coordinate and even leverage resources moving forward and across the continuum. And so all the themes sort of coalesced into this picture or this story. And of course, we do have a bias, and Andy's right, because I would say to him, Andy, am I seeing this in the literature, or am I seeing what I want to see? So, part of it, we bring our own bias into the literature. this was very evident. We've lived with this policy framework, right? This is the meaningful use framework, beginning with stage 1 in 2011. So we've seen a lot of structured data capture and probably more institutional than patient-generated data. I remember Patty Dyke saying last session, thank God for open notes, knowing that patient or that person interface. Lots of clinical decision support to assure adherence to practices. And a lot of work looking at transitions, but primarily between institutions. So we might call this very early care coordination as we move along to stage 3 meaningful use. I suspect, and please let me know if you agree, that most of the performance and quality metrics are probably still payer-driven and institutionally driven. There's far less clinical decision support for nursing practice. Would you agree? The clinical decision support tools that we have, there's less support for nursing science than is needed. And there was one article, and as Andy talked about, the change in settings where the EHRs themselves became settings. It's because of big data analytics and now our ability to query these, query the systems that are pulling in more data. Oops, wrong way. So moving forward, I am very mindful of this work. And if you were here last year, one of the authors, I think Andy Phillips, may be related to your dissertation research. I'm not sure. But if you recall from last year, essentially what these authors are saying is that even though, and I think the estimate was about $30 billion at the time that you pulled together this work, even though we've put in billions and billions of dollars to transform the delivery system, we're not seeing a transformation. So if you look at the observed and think about what might be a tipping point. So Andy talks about this revolution right in this area and internal changes that are required, perhaps deep structural changes, policy influences, and patient empowerment. And so what this really says to me is this is a call to action, really, for consumer-generated deep structural change in the healthcare delivery system. So here's the first article that I think brings to life some of the deep structural change that we might need moving forward. So the nurse here, not first author, but rather Gail Keenan. So I think we've looked at Gail Keenan's work in the past. And essentially, I think Patty mentioned her work last year. I think that Gail's vision might be that for nurses to have at their disposal access to nursing science so that I'm not reinventing the wheel with every client interaction. Rather, we can begin to pick up where our colleagues may have left off. And what she does is demonstrates using this knowledge discovery model, this broad application of knowledge discovery. And yeah, we heard some elements of that from Jane, work at HCA with, I think, CCC. Gail uses Nick, Knock, and Nanda. But what's important is the use and reuse of existing data. And so what this team has done in 4 Midwestern hospitals, I think they have a total of 9 units, they've begun to apply something, big data analytics, primarily associative analytics, to a data repository of, and it's hospital generated because that's where we have access to the data, nursing care plans, over 300,000 nursing care plans from 35,000 unique patients using this knowledge discovery framework. And what they were able to do is confirm the benefits of standardized language and knowledge discovery from 3 different perspectives. From the consumer perspective, in terms of consumer choice. So imagine, if you will, that consumers shopping around for institutions are shopping around for institutions based on NOC outcomes, nursing outcomes. And the example that she uses is comfortable death. And the finding was that the NOC scores, looking at 9 units, the completed NOC scores of the highest level, representative of comfortable death, was a higher percentage in gerontology units versus the other 9 units across these 4 hospitals in the Midwest, the institutions in the Midwest. And then from the clinical perspective, specifically the nursing perspective, she uses NENIC. But the example that was used was fall risk, and we've heard a little bit about this earlier. And what was really cool is it brought to mind bundles. You're familiar with IHA bundles, VAP bundles. And so what if we have NIC bundles or nursing intervention bundles, and so we use up to 5 of them. And I can see that we've used up to 5 of these. Well, what they were able to find is that when bundles were pulled in from the family and social domain, there was value added at the margin by adding these additional bundles. So this begins to influence things like institutional outcomes. And again, querying this database that supports nursing science, another example that was used was looking at readmission rates. And based on the data that they had, which is limited, but the data that they had, they were able to identify that when young persons who had a particularly long length of stay in an institution also had nutrition problems, they were more likely to be readmitted. So are you getting the gist of how we're using the data to support our role as knowledge workers? We're, moving away from, I think, Sarah mentioned something about there was a missing wisdom, and I remember you said in the last year, well, that didn't come out right, but we weren't able to leverage our knowledge. We weren't seeing the wisdom, the knowledge discovery cycle. The nurse in the case of this publication is Matney. I don't know if you're familiar with Matney's work, but she serves on a lot of the standards organizations. And essentially what she's reassuring us is that we can use existing data standards that are supported internationally and nationally by ONC and effectively communicate nursing care. So we can map, I don't care what language you're using, if you're using NIC, NOC, NANDA, CCC, or I think there were something like 12 of them. Matney actually says, you know what, you can map them to SNOMED CT, LOINC and SNOMED CT, using HL7 standards, they'll map to this, this continuity of care document, this consolidated, that moves the information with the patient. And again, it seems that we're better at moving this patient information from one institution to another institution than capturing the patient's story across the continuum as much as we would like to. So capturing the story is difficult, but it is possible using standard ontologies. And this is amazing because I think all of the poster presentations that I've seen or many of the poster presentations are in this space. And so this is an interesting article looking at automated alerts and reminders that were sort of pushed to patients at review of the literature. And 23 out of the 51 studies were randomized control trials, which is really great to see. And essentially, this investigation into the efficacy of using these things in the area of patient self-management, it's shown to work. This stuff is working. But here's the problem. It's in the economic evaluation of the studies. So they're very limited to one institution. So for example, I may find that if I send a message of an appointment reminder to someone from my institution, then I'm managing my appointments better in my institution so that there are fewer missed appointments, which assures revenue to that particular organization, but it's not looking at a more comprehensive economic analysis that would say, well, what does this mean for public policy? Is the fact that the person made the appointment really adding value, looking at a broader perspective of healthcare and healthcare expenditures? So a more comprehensive economic value must be demonstrated if we're truly to inform public policy. And second author, actually, on this is Patty Dykes. And what I love about this article is it seems to bring the whole story or the whole picture together in a wonderful way. And essentially, the question here was asking, okay, so to what extent is HIT involved when we're transitioning patients between these different settings? And so these authors used both a literature review as well as expert opinions. So they queried people from institutions across the country. And lo and behold, what do they find? Gaps in care coordination due to interoperability problems. And what I really like about this article is if you look at Table 6, where in the first column, I don't know how well you can see this, is the current capability of HIT. And then in the second column is the future potential for HIT. So essentially what they're finding or what they're arguing is that there's unrealized potential. So we have invested tremendous monies. I think the original amount under the High Tech Act was something like $80 billion that we would invest into health information technology to transform the system. But we're not realizing the potential of that investment. And if you look at areas where there's predicted high level of future potential for HIT, supporting self-management goals. Well, yep, certainly we saw that. Also linking to community resources. We're not doing that particularly well. These authors suggest that if we just added a zip code, then we'd be able to identify resources that are, in a community area based on zip code alone. And certainly to help us better align resources with population needs. Reminding us, and this is actually an important point, that not all processes of care should be automated. So I'm sort of reminded of if I'm educated to hammer, then everything looks like a nail. Likewise, if we're educated to automate, then everything looks like an opportunity to automate. But perhaps not if you look at the interpersonal dimension, the interpersonal communication dimension. So we still don't know what's the right dose of interpersonal communication and how important that space is and how we're augmenting it with information technology and not replacing it. We're still struggling, I think, in that area. That's all I have.
Okay. All right, I saw the 5-minute sign go up, so I have to do my slides in what, 2 minutes? Watch this. All right, here's where bias comes in. Great article. First paragraph compares baseball to nursing. This was awesome. Whole first paragraph is about Field of Dreams, the movie. Anyone seen that, right? It says, if you build it, they will come. Great article. And then it says, it doesn't work in healthcare, right? You build it, they don't necessarily come. So it was a real letdown after that first paragraph. But I have to include this article because it talks about baseball. So the short of this one is that a lot of these technology acceptance models have been tested and used across settings. And we need to spend more time looking at these models and how technology is accepted by the users. There's still agreement that satisfaction and intention to use are still predictors, strong predictors, is what the chart on the bottom says, strong predictors of actual use. But the question is, are there things we need to be focusing on more in healthcare that might influence those? And what these authors found is that the usefulness toward care delivery was the strongest indicator of both intention to use and satisfaction. So starting to pull in, the implication here is starting to pull in some of these other healthcare related issues into some of these existing models can strengthen these models and hopefully help improve acceptance and use, more importantly, use of these systems as they're implemented throughout an organization. The other point on this one is that in the model, they also tested and looked at social influence, so social community, those kinds of influencers, how much does that play into it? And the patient-family engagement, so how much does the technology help you as a nurse engage the patient and family in the care? So I thought that was another interesting point there, and that actually had a significant influence. It was shown, it's one of those 4 boxes there, which are impossible to read because you can't read them. But the bottom one talks about the middle one, the third one of them does, talks about the strength of the patient and family engagement and the influence of that on the nurse's intention to use the system that's in place there. Okay, next article, process improvement and quality. I had mentioned that before. My past life before I was a nurse, this is all I did. So I have to include this as well, again, bias. But this was really, this was actually really interesting. And there is a nurse there in the authors, I don't remember who, but this impacts nursing and it impacts organizations. And it takes a look at a particular quality improvement process, in this case, something called failure mode effects analysis, which really briefly is you write down the process as you know it, and you try to identify those areas of failure or those areas of highest risk, and you try to rework your process around that, all right? And what they wanted to do in this study was look at how do we check and make sure that that's actually working or not. So we have an idea of what the process is. Can we use data that's now available in the electronic health records to help us map that process better? And what would that data tell us? So when we log into a system, we know who's doing certain things. So if we map out a process on a piece of paper and we think this is the ideal process, we could actually start using some of the electronic health record data to show us are the right people doing the right pieces of this process that we mapped out that's supposed to be the perfect process, right? And what they found was that wasn't the case. So every box that's yellow here is an area that they found that the person who was supposed to be doing it wasn't doing it. Amazing, right? So you actually map this great process out and you implement it, and what they found was if you actually looked at who was doing that particular step of the process, the actual number is that 35% of the activities were completed by unexpected people. So people that they didn't expect to be doing that process were actually doing the process. Interesting, right? Thought that was just fascinating. So all those yellows are the people that you didn't really expect to be doing that process. And the process that they had as an example that they mapped out, there were supposed to be 7 types of people that were doing the process, and they found 19 people involved in the process instead. So how processes are actually implemented, the end, is important. And I have some really gorgeous charts here. You can look at this chart, but this chart essentially talks about those areas where you have a high degree of the people doing it aren't who you expect versus those areas where you do have the people that expect it. And the process they were mapping out was the discharge process. And then the last one, as quickly as I can, is I just had to include this because this is the, how can you resist someone who's writing an article about pagers, right? So, all right, how important are pagers to medicine, right? But it's good, right? We're still using all of this technology that's existed for years, and we need to start looking at it again and finding if it's helping or hurting or what it's doing. So this particular article wanted to know what was the quality impact of paging data, and does it contribute to any kind of communication failure? So does having this old technology around actually contribute to any kind of failures or new errors or new risks? They looked at all of the pages in a particular hospital setting. Turns out that there's 2 to 8 pages per hour per physician. And the implications are that it's tough to move away from these technologies. They're used a lot, and it's hard to do that. And it creates a significant amount of duplicative information. So you get paged, you get something in the EHR, you get something somewhere else. And what are we going to do about all of this duplicative information? We don't necessarily want to give up this technology, but it is starting to clutter some of the information we have. And I didn't quite do it. Step 6 of the method
I know,
was
that's the
consultation,
most
was feedback from you.
important part. Yeah, feedback from you.
But we are out of time. I'm getting the hook. All right, thank you.